First of all, this week I want to apologize if my presentation sounds a little more nasal even than usual, and I do know that I have some sinus issues, and that's usually pretty clear when someone listens to a recording. I can hear it when I listen to a recording of myself. Um, I have a sinus infection at the moment, and so it may be a little worse than normal. And I'm going to do my best to control the sniffling during the course of the lecture, and hope that you'll bear with me uh, through this lecture and the next this week. Chapter 18 addresses the issue of disasters and the response to disasters and threats of violence. And so this week we're going to be looking at such very familiar issues as post-traumatic stress. Post-traumatic stress, or PTSD, has been used so much and described as the condition that we're observing or experiencing sometimes that it really has watered down the meaning of the terms. And so uh, our author does take some time to try to help us kind of refocus and understand what exactly PTSD is supposed to entail, rather than sort of the popular use of the term that seems to permeate so much of our discussions anymore. First, we take a look at the DSM-4 definition of post-traumatic stress disorder, or PTSD, and the slide points out that there are symptoms that include a re-experiencing of the trauma through such experiences as nightmares or intrusive thoughts during the day. This you may hear people say, sometimes I just can't get this out of my head. I keep reliving what happened. I keep remembering this. I keep feeling these emotions associated with this trauma. That's sort of what they're talking about here, about the re-experiencing of the trauma. Oftentimes, though, a numbing, sort of by trying to avoid reminders of the trauma, or really being unable to express kind of feelings that one would normally express. That's something that's not uncommon after an experience of a trauma like that. And then persistent symptoms of arousal by two or more of the following. And the DSM-4 often gives you a checklist of different kinds of behaviors that or experiences that a person might come across, and so you have to check off two or check off three of these items for this to really apply. And so in this event, it's two or more of the following, which would be sleep problems, irritability or anger outbursts, difficulty concentrating, hypervigilance, exaggerated startle responses lasting more than a month, and then these things causing problems at work or in social relationships or other important areas of life. And that's a key part too, as well, is the we may experience after witnessing a trauma or being involved in a traumatic event, we may experience some of these things for a period of time, and that's to be expected. Where we begin to look at diagnosing it as an issue is when it's really begun to intrude in life and over an extended period of time. So this says the condition is acute if it has lasted less than 3 months, chronic if these experiences continue for more than 3 months. Now that's the official DSM-4 diagnosis. But as I mentioned in the opening here, it's just really kind of overutilized on such a wide scale for just every tragedy that occurs, and there are predictions of post-traumatic stress and everything, that it really is less useful than it once was, this particular diagnosis. Oftentimes, as I mentioned, it is after an event such as this. It's normal to experience these kinds of responses that we just described, and so these things, though, for most of us, will be overcome with time, and as we're further and further away from when the event occurred, and we get back to normal, and we begin to able to deal with things much more normally. So in the immediate sense, after a traumatic event, it's a normal response, and it's not something to be worried about. And they say here that that really a lot of people were surprised at just how much lower the actual incidence of post-traumatic stress in victims of the World Trade Center bombings turned out to be, some 4 months later. And you can hardly think of something much more traumatic than something like that if you witnessed that or had a loved one associated with it. So there are four general categories of symptoms with post-traumatic stress. That is one, the re-experiencing of the traumatic event, another, avoiding situations associated with the event and feeling of being numb, and then having extra anxiety or anticipation of feeling upset as well, just in general. Different people are more prone to develop post-traumatic stress symptoms than others, and certainly the severity and duration of an individual's exposure to the trauma is one of the most important factors in determining whether or not PTSD is likely to develop. And there are other factors that contribute to PTSD, as they say here, including, individuals not having the social support that helps us, nurses us all through, hard times and difficult situations. If there are histories of family trauma or childhood experiences, because sometimes present-day traumas can connect back to those experiences and cause unresolved things to be re-experienced again from many years before. And if the person already has an emotional problem, they're most likely more prone to a response to trauma like this. This also says that people are more likely to have symptoms of PTSD if they have experienced an intrusion into their life, such as job loss or broken personal relationships as a result of the disaster itself. If you have experienced a death or illness of a family member or close friend because of the event, also is another thing that is likely to contribute to the possibility of developing PTSD. And of course, as I said earlier, one's individual emotional state is also likely to have a bearing on how things shake out in the long run. Again, I will say, experiencing trauma is likely to result in emotional responses and in some psychological difficulties for some period of time. There is nothing abnormal about that. It is when it stretches out and intrudes in our lives that in a bigger way and on an extended period of time that it becomes something that may be diagnosable. Also, here there's some other things, sort of from a sociological standpoint, when they look at environmental concerns and health risks and things like that raise the likelihood of repeated traumatization and therefore increase the probability of developing post-traumatic stress disorder. If you live in a high crime area, for instance, it is very likely that, for instance, hearing a gunshot may stir up a lot more emotions and fear in you than the simple startle response you might experience if you lived out in the country and you heard somebody shooting a gun in the distance, thinking somebody's hunting or target practicing or whatever. So your environment also shapes a little bit about how it is that you respond to these kinds of things. This also talks about the fact that being exposed to violence in our childhood and in our families, or having been assaulted by other people unexpectedly, those kinds of things, having been raped or molested, all these things also contribute to forms of post-traumatic stress disorder. And it is, Stein says, the repeated acts of violence in one's life is one of the things that maybe increases our vulnerability to developing PTSD. Post-traumatic stress in Vietnam vets, and this is where we first started hearing the terms post-traumatic stress, was as an aftermath of the Vietnam War. With there is sort of this image of the Vietnam vet that does kind of hold up in a shack in the woods and doesn't want to interact with the world, and lives as a survivalist and those kinds of things. That that really most all of the vets that returned from Vietnam did not experience that kind of thing at all. But and certainly that would be a more severe kind of response to that. There are vets that I know from Vietnam, in fact, who fought over there but don't ever talk about it and don't want to talk about it, and in a way that could be seen as a symptom of post-traumatic stress, one form of it at least, but then again, it might be just a healthy way of kind of putting it away and leaving that experience behind, and it's not necessarily post-traumatic stress. But it says here that about 9% of the men and about a quarter of the women that served in Vietnam experienced post-traumatic stress at some point since the time of their service. This is not something that has to continue all their lives. They can be treated and resolved, of course. And through different kinds of interventions and things like that. But it says about 830,000 Vietnam vets continue to experience post-traumatic stress 20 some years after their exposure to one or more of the traumatic stressors. In the civilian populations, lifetime PTSD prevalence rates are somewhere between 2 and 10%, so that's of course lower than those that have been exposed to war. That it says here that although more than half of the population of the United States has been exposed to one form of traumatic stress or another, a very small percentage of them actually develop post-traumatic stress disorder. So that suggests that, as you would hope, most of us are able to resolve the issues related to the trauma successfully over a period of time. One of the areas where PTSD is used and in diagnosing is the victims of abuse and neglect, childhood abuse and neglect, as well as sexual assault, sexual abuse, and rape. And so there is some time and effort given towards understanding this dynamic a bit in this particular chapter. 1 out of 6 American women have been the victim of an attempted or completed rape in her lifetime. That is about almost 18 million women then who have been victims of attempted or completed rape. This is perhaps a surprising statistic to you that 15% of the sexual assault and rape victims are under age 12. And the age group and gender that is most vulnerable are girls aged 16 to 19, that they're 4 times more likely than the general population to be victims in this particular area. Some of that, I believe, you're talking about some college freshmen and young women essentially who are experimenting with heterosexual relationships and that kind of thing. In my family violence course, we talk about this phenomena some, and the author of that particular text points out that perhaps one of the most dangerous venues for a young woman is a party. Is a party with peers where there's alcohol being served, and as far as sexual assault goes, that a lot of the sexual assaults occur are by acquaintances and in environments such as that. So this may be one of the reasons why this number is a little higher. And their estimate here of 3,204 pregnancies in 2006 as a result of a rape is an estimate, and I think it would suffice to say more than 3,000 pregnancies. You can't get quite that specific when you're estimating, but there's about a 5% pregnancy rate from sexual assaults. About 8% of women will experience rape by an intimate. That is about 1 in 12. If you were sitting in a classroom with 24 female classmates, you could pretty much predict that 2 of those classmates at least had experienced rape by somebody close to them, an intimate, whether that be a parent or somebody like a boyfriend or somebody that they were connected to. Now, of course, you have to understand that this is one of these points of education for young women, I think, is understanding that because one is married or because one is in an intimate long-term relationship, a committed relationship, the male doesn't have the right to demand sex when the female doesn't want to engage in sex. And so sometimes, particularly young women are raped and sexually assaulted and don't frame it that way. They see themselves as this, whether it's a duty or perhaps they had been drinking too much and were less apt to or less able to make a good informed decision, and the male took advantage of that, and she sees that as her own fault perhaps or something. These are incidents that really is acquaintance rape or intimate partner rape, and is more women probably experiencing this than we realize at this time. It also says that almost a quarter of women will experience some sort of physical assault by intimates during their lifetime as well. As you look through these statistics, keep in mind that there's often comments made that that males are the victims of domestic violence just like women are, and this is one of the things we're talking about here, because domestic violence certainly involves sexual assault and rapes by intimate partners. One of the reasons why domestic violence is much more a women's issue and should be thought of as primarily as a women's issue. While there certainly are male victims of female perpetrators in domestic violence, the fact is that women suffer far more harm at the hands of violent male partners than do males at the hands of violent female partners. And the results, well, certainly, first of all, it's much more frequent. Women are seen in the emergency room very frequently for these kinds of problems, and so it really is a women's issue, much more than a man's issue. And here are some statistics that tell you why that is, that they're 7 to 14 times more likely than men to have been beaten, choked, or threatened with a gun, or having had a gun used on them by intimates. They're stalked 8 times more often than men are. They're raped before the age of 18. Women raped before the age of 18, are significantly more likely to be raped again as adults. And this goes on to talk about how the sexual traumas then that have these very serious emotional consequences that really can carry on throughout the woman's life and affect their intimate relationships, consensual intimate relationships in the years ahead. And so post-traumatic stress is one of the results of this kind of thing. And I think in this particular area, this is it is a legitimate place to diagnose post-traumatic. We've talked about resilient children and resilient individuals previously in this class, and so I'll just let you look at this slide again to see the different definitions of resilience. I think we're pretty familiar with what this means. But the point of this particular slide is to suggest to you that why is it that some people experience PTSD and others do not, may have something to do with this notion of resilience, and that some people just are more resistant to the traumas associated with it for whatever reason. And the one study that I think is kind of new and interesting, perhaps compared to what we've looked at before, is the Werner and Smith study at the bottom. Is from the early 1980s that said that certain factors reduce the risk of stress in any situation. And just look at this in plain terms, an easygoing disposition. Well, okay, so nothing much, it's like water off a duck's back. And that, it goes without saying, but that may seem like duh kind of a thought, but the fact is that that's an important thing, that some of us are better able at just letting things kind of roll off our backs and not be bothered by things than others are, and so those individuals have a certain resilience to them that may help them cope with trauma much more effectively. Strong sense of self, a good self-esteem, a sense of identity, intelligent, they're able to kind of understand from a sort of an intellectual perspective how these things happen and how the usual course of things are and how it does and doesn't have to affect one's life. Physical attractiveness, which is an interesting thing. I guess that means that if you're good looking, you're going to have more people around you, is my guess. I think generally speaking, attractive people attract. That's why they call them attractive. Attract people to them, and perhaps that explains why that's a contribution here to resilience. But supportive friends and loved ones are attracted to you. I kind of think that's kind of a funny little factor, but that's one of the things that they found that tied into the reduced risk of stress. Natural disasters, and which is certainly something that's an issue for Alaskans, with earthquake and of course, the great earthquake of 1964 is an example of that, and there are still some individuals, I think, who lived through that quake who experience a certain higher level of anxiety, I believe, when we have a tremor, that most of us are pretty used to living in Alaska, but there's different meanings to that to different people. And if you live through that quake and we're in an area deeply affected by the by the tsunami or the quake itself, certainly those kinds of things are going to affect you more deeply. 1/3 of the studies of individuals living through natural disasters had significant distress, and post-traumatic stress being one of the symptoms experienced, as well as depression and other anxiety disorders following later. Some health problems and just anxiety about their situation after the natural disaster. And it says here that, again, severity of the disaster certainly is going to impact how severely you're affected by it. It also says that if you're a female, you're more likely to have a higher level of stress about it. Women might have an objection to that, but this is the statistical, whatever this study was. This is sort of what came out of this study by Bland in the 90s. Being of middle age, ethnic minority group membership. I suspect that has something to do with the fact that there's less certainty of the availability of resources to you when you belong to a minority group, and we'll talk about that in another few seconds as to why that might be. That would likely increase stress in a natural disaster. Other kind of psychiatric problems, those kinds of things, also are going to contribute to one's proclivity to have difficulties following a natural disaster. Now, this slide talks about Hurricane Katrina, and I don't know how many of you actually were watching the news. I think this was in 2007 or 2008, late in the summer, when the hurricane blew through New Orleans and virtually wiped out the largest part of that city. And New Orleans is and has been known for a long time to be a city that is much higher than normal, or higher than average percentage of African Americans living there, and many individuals living below the poverty level in that city. And when Hurricane Katrina blew through, as if you were paying attention to the news, if you read about it since, the federal government's response was almost lackadaisical, very slow. There's been a lot of criticisms to FEMA, which is the Federal Emergency Management something organization, association, whatever, administration. That's what it is. Federal Emergency Management Administration, which is the federal government's arm of dealing with natural disasters and things like this, and FEMA's response was pathetically slow. And if you watched television during that time, you saw images of individuals, on rooftops, without food and all those kinds of things. And it was just a terrible, terrible way for the government to respond. It was difficult for myself. I remember I had an exchange student living with me, in fact, from Denmark that year, and he had just arrived a few weeks before that, and Denmark's a pretty prosperous nation itself, and he was sitting there scratching his head looking at this, and I said, it's hard for me to imagine that this is actually in the United States in an urban area that we're looking at this, and that 2 or 3 days later this is still what's going on there. It's just something I had never seen before. And so certainly the individuals that lived through that experience, many of them African American, being stranded and losing loved ones very, very traumatically. I mean, they're going to experience long-term emotional problems, and part of the reason for this is because, they may believe that they're not cared for by others. That certainly they have little control over what happens to them, or lack of the physical ability to deal with stress and things like that, resources not being available to them, but also just that first bullet point there, that when people think they're not cared for by others, they're likely to have more stress when something happens, because they don't believe they can fall back on the resources that those of us in the majority know we have available to us, or at least we think we have available to us. As far as terrorism goes, the rate of post-traumatic stress in those living close to the World Trade Center, according to one study, something less than 500,000 New Yorkers as a result of September 11th. A survey of another 8,300 public school students indicated that about 10% of the city's 700,000 public school students experienced symptoms of post-traumatic stress. That's about half of the overall rate. Doesn't surprise me too much when you think about being middle-aged as being one of the things that's going to increase the likelihood for experiencing post-traumatic stress symptoms. The youth are oftentimes thought to be more resilient, and so that's not surprising that it would be half the overall rate. As an aside, as we talk about the World Trade Center and post-traumatic stress, I like movies so much, and I like to refer to films and things, and there is a film called Extremely Loud and Incredibly Close. Many of you may have seen it already, but if you haven't, I'd suggest to you that you add it to your film list. It's bit of a tearjerker, and so just be prepared for that. But the film is about, I think, a boy that's probably some form of autism spectrum disorder or whatever. Just kind of a quirky boy, perhaps Asperger's syndrome is what he would be diagnosed if we were going to open the DSM-4. Who loses his father in this in this the September 11th event, and it's the one film that I have seen that actually deals with a child's reaction to September 11th, children's reaction to September 11th, and his, well, I think you see him working through his symptoms of PTSD kind of on his own in this film. It's really an interesting movie and a very touching story. It's, I believe, fictional, but nonetheless, I think probably reflects some of the experiences of the kids who did have that event impact them. So I'd recommend it. The movie's name again, Extremely Loud and Incredibly Close. There are different kinds of interventions that can be done for post-traumatic stress disorder. I had a friend when I worked at the mental health center who had some training and experience in working with victims of trauma and post-traumatic stress in particular, and he talked with me a bit about what he did with his clients. That he would because one of the things that PTSD victims often experience is a fear of really kind of confronting the issue that the event or whatever in their memory, almost as though by thinking about it, the harm can come back to them. And one of the things you want to help the victims of PTSD victims understand is that the event's not going to be able to hurt them like it did the first time anymore. That they do have mastery over their emotions, and they can manage their response to this. However, if you flood your client with this and you take them through this too fast, you'll lose your client because they're not ready to really confront things that quickly and that brutally, and so you have to be patient as a therapist with these individuals. And he said he would tell his clients it's kind of like going up the steps to the attic in your home, and there are boxes and boxes up there of things that you haven't looked at in years and years and years, and things that were stored away, and you've probably forgotten about a lot of them even being present. And that what therapy is going to be like is just walking around that attic and looking at the different boxes and identifying maybe what's inside of them, but not opening them until you're really ready to look at what's inside, and that the boxes would be open at the rate that the person is comfortable with, and then going through the contents of the box. And I think that was a very good way of kind of talking about a little bit about what the exposure therapy here is about, which is really kind of helping. And there's other ways of going about this. It's not always just talk therapy. If a person is in say a automobile accident and they haven't been out on the expressway since then, is gradually getting them closer and closer to getting on the expressway, and maybe taking them for a ride and then having them drive, and those kinds of things, little by little, kind of helping them to get back in and deal with whatever it is that they experienced, and help them work through those feelings, see that they survive the existence of those feelings when they happen, and helping them pass that. And so this is one type of intervention that can be used, and there are others as well. It's really beyond the scope of this class to really train anybody in how to deal with post-traumatic stress or any other condition for that matter. And again, I want to stress, this is not preparing you to do that. This is just telling you about the kinds of things that can be done. Another approach is a debriefing, and this is something that more locally, and I think around the nation, has been referred to as critical incident stress debriefing, CISD. And in our area, 10 to 20 years ago, perhaps, there was really, maybe a little longer than that actually, quite a movement to train the professionals in the area on how to do CISD interventions with individuals, and in particular, this is something that they were trying to use with hospital staff or with ambulance staff or emergency response personnel, those individuals who dealt with a particularly gruesome scene, perhaps. Many years ago, I remember one time, in fact, where there was an accident that involved, I think, 4 or 5 adolescents, and a couple of them died, and the CISD team kind of brought them together to kind of work through what happened. Now, with emergency responders, one of the things that I think, and I'm not an emergency responder, but it's pretty clear to me at least, and I think to a certain extent law enforcement as well, who is an emergency responder, of course, that they learn to manage their response and to not connect emotionally to what they're experiencing, because that's how they can work through that trauma and deal with it effectively. Um, and one of the I think the tenets of debriefing is that you don't then have them sit down, 2 weeks later and ask them to cry about it and experience their emotions. That's not where you go with this, and that instead it's more of an instructional, educational thing, and it's a very managed kind of thing where individuals are given an opportunity to talk about what they experienced, but not to go into it in depth. And if individuals needed that they were referred to other resources and things. So debriefing has been another way of dealing with stress, and particularly with professionals who deal with stress. It is something, incidentally, that child protection workers might benefit from, but is rarely offered to them. Part of the reason being, as social workers, we think we're supposed to be in touch with our feelings, and so that's well, I'll talk about secondary trauma in a moment, but in any event, it's interesting here that it says that although this approach has a lot of appeal to it, that the studies don't show that it works, and in fact, the last sentence says it may be less effective than not doing anything at all following a trauma. And so I don't know what exactly that means. How can it be less effective than nothing, unless it says it's hurting people? And I don't think that's what it's saying. But in any event, it is still used, and certainly some people benefit from it. But in the bigger picture, perhaps it's not as effective as was once believed. Let me just take this opportunity to talk a little bit about. I'm going to go back to this just for the sake of keeping us focused here. Social workers and human services workers deal with trauma a lot, and as well as this slide tells you, and as the next slide will point out also, we're there a lot of times in the midst of whether it's natural disasters or it's after a man-made trauma or an accident or something like that. We're there to, as a profession, to help individuals, and in fact, some workers are signed on to community organizations that volunteer to step forward and help out in times of disasters and things like this, separate and apart from their paid employment. And so social workers have to find a way to manage their responses to these events. As was mentioned in the last slide, the first responders a lot of times I think, learn to kind of close themselves away from the emotional reactions, because they have to be able to keep their focus. And while social workers occasionally are first responders, usually we're not very first responders, but very close afterwards. And if we don't actually witness the trauma and see the immediate aftermath and all the horror associated with those kinds of things, we are talking with people who have lived that frequently, day in and day out, and we're dealing with victims of abuse and of assault and of violence, day in and day out. And there's a phenomenon known as secondary trauma or secondary stress that has become more talked about in the field recently, and particularly in child protection. The agency had, at least for a period of time, there was a kind of a well of interest in this, and encouraging workers to learn to practice self-care. I would like to be able to devote a little bit of talk to that later on in the semester. It's really not in this text, and it should be, but talk a little bit about that with you, and you'll be certainly hear more about this in your education. But by constantly exposing yourself to the events that your client has experienced through talking and listening, or helping them work through their own events, sometimes we carry home some of the symptoms of post-traumatic stress, or the intrusive thoughts, or those kinds of things, and it's very important for us to know how to deal with that, how to recognize it, if we need to get help, but that otherwise how to practice the kinds of things we need to do to take care of ourselves emotionally. And I think there are some things that we can do with or without repeated stress is very important in the field, and we'll talk about that later. But the bottom line is remembering always that this is, while you're devoted to this and while you want to do the best for your clients and you care deeply about the people you work with, this is your employment. It's your profession. It isn't your life. It isn't you. And you have to take care of the you part and your home life and your family life. You have to leave work at a decent hour and learn to relax, because if you don't take care of yourself, you're not going to be able to take care of your clients very effectively either. So that's the short run of this as far as social work is concerned. And I'm a little disappointed again with this text in that it doesn't touch on this, and maybe he just doesn't think this is appropriate in this particular chapter, and perhaps it isn't. But in any event, if I can, I'd like to pull a few resources together before the semester's over and just give you a little talk about that. Oh, organizations that help victims of violence, and some of the ones you're very familiar with: Red Cross, Salvation Army, religious charitable organizations that will sometimes be there to provide immediate help for people experiencing traumatic events. Certainly, as the slide also indicates, police departments and law enforcement agencies also are first responders, and workers often work for them or closely with them. This mentions the Department of Homeland Security, but that's really a much more macro kind of an organization. It's supposed to prevent and reduce the likelihood of further terrorist activities, and not really, I think, an organization that really helps victims directly. It also here mentions FEMA, which is an arm of Homeland Security that, again, got some pretty bad raps after the Hurricane Katrina disaster. But FEMA is also there to kind of help people cope with some of their immediate needs, housing and whatever it might be, after a natural disaster. Workers, what do? I mean, we provide help and support, and sometimes the basic kinds of support first, following along with what Maslow says, that if somebody's life needs aren't met, they're not going to be able to deal with other things. And so the first and foremost is we make sure that people have housing and food and clothing and, those kinds of things, and get help through that immediate crisis. And then we evaluate them for more about what are the kinds of things they might have in the long term as far as needs are concerned. Maybe arranging for them to see other professionals or service providers, if not ourselves, in the long run, and if necessary, relocation sometimes is another service that workers might help with, and but generally also involved in providing support and counseling services for anybody that have persistent problems following a traumatic event. There's some statements here about women following not only like traumatic events, but the more personal kinds of things like sexual assaults that need to have their experiences validated. And by that, I think that the not surprising, of course, that oftentimes victims of assault feel as though that no one in the system really understands them, and indeed, the way the legal system works, sometimes the victims feel as though they've been re-victimized by the legal system because of the way such things as sexual assault are handled, and so it's important for individuals to listen and validate and to believe and support what they say, and to support the victim's perspective on the event. And to encourage and reinforce them for any attempts they do make to deal with their traumas in an effective way. PTSD, most people think that you get over it on your own, but this is probably not the case. One of the things I'm going to refer you back to something we talked about earlier, which was the Adverse Childhood Experiences ACE studies by Kaiser Permanente that assessed the individuals who were, I think, enrolled for healthcare services with them as adults and functioning fully in a job. So this was healthcare. Health insurance for working people, and surveyed them to about the kinds of things that happened in their childhood, the traumatic events or the things, the negative experiences, such as having a parent incarcerated, or having experienced childhood neglect, or having been physically abused, or having somebody use drugs or have an alcohol problem in their home, those kinds of things, and very, very positively correlated. The more adverse childhood experiences the individual experienced, the more likely it was that they were going to be coming for services for health problems, not psychiatric services necessarily, but for stomach problems and and anxiety, other kinds of physical problems, not necessarily emotional, certainly emotional as well. And so what it says is, and why I'm mentioning it here, is because it really tells you that when these things happen to you, you just don't get over them. I mean, and that's what a lot of people think. Oh, just let them go, and they'll put it in place. Sometimes resilient people do that. We don't really know if resilient people really do that, or if they just have a kind of a better firewall of dealing with it. That their responses may still be there. We don't know because they don't even experience it themselves. But in any event, the point is that trauma doesn't just go away. A lot of times the impact of trauma can linger with individuals, and sometimes much later can require some interventions, not even at the time of the event itself. So that's sort of the closing thought here I would leave with you with this, and hope that you found this chapter useful to you and educational. So if that's it for this particular talk, take a break and come back, and we'll talk some more about something related to